Alveolar bone. The alveolar bone or the alveolar process is the part of the maxilla and the mandible that forms and supports the sockets of the teeth. This forms a part of the periodontium. The functions of the alveolar bone include that it houses the roots of the teeth, it anchors the roots of teeth to the alveoli via the Sharpie's fibers. It helps to move the teeth for better occlusion, helps to absorb and distribute occlusal forces, supplies vessels to the periodontal ligament, and supports and protects developing permanent teeth while supporting primary teeth. It also organizes the eruption of primary and the permanent teeth. Now, a look at the development of the alveolar process. The alveolar process develops from the dental follicle. The dental follicle, as we all know, is part of the structure of the tooth germ, which provides the periodontium, the alveolar bone, as well as the supporting tissues. The proper development of the alveolar process is also dependent on tooth eruption and its maintenance on tooth retention. So if the teeth fail to develop, the alveolar process will fail to form. Likewise, once the teeth are extracted, the alveolar process will reduce or diminish in size. It will get resorbed. So the presence of teeth is a prerequisite for the presence or development of the alveolar process. Now, coming to the structure of the alveolar bone proper, the alveolar bone is divided into two main parts. The first is the alveolar bone proper, and the second is the supporting alveolar bone. The alveolar bone proper is what we are seeing here. This has multiple perforations, so it's also called the cribriform plate or the laminar dura, which is a radiographic term, and it is also called bundle bone because it is comprising of bundles of periodontal ligand fibers within its histological structure. The supporting alveolar bone makes up the inner core, and this contains the cortical plates, the outer and the inner. This is the outer and this is the inner cortical plate, and in between we have the spongy or the trabecular bone. So what we are seeing, the part which is immediately lining the tooth is the alveolar bone proper, and which is also called as a cribriform plate. And on the radiograph, which is seen as a white line, it is called as a laminar dura and also bundle bone. These are all terms which are used to refer to the alveolar bone proper. The supporting alveolar bone comprises the outer and the inner cortical plates as well as the spongy bone in the center. The alveolar bone proper consists of partly lamellated bone and partly of bundle bone. It has a thickness of about 0.1 to 0.4 millimeters, and it surrounds the roots of the teeth and forms the inner wall of the socket. It also gives attachment to principal fibers of the periodontal ligament. Lamellar bone contains osteons, comprises of Haversian canals and concentric lamellae. Bundle bone is that bone in which the principal fibers of the periodontal ligament are anchored, and the reason for this is what gives it the term as bundle bone, because of bundles of periodontal ligament fibers which get anchored. So it is termed bundle because of the bundles of principal fibers of the periodontal ligament which are anchored into it, and it is seen immediately lining the socket, and it is a prerequisite for tooth support. The histology of bundle bone shows that it has less collagen fibers than lamellar bone. The fibers are seen at right angles to the Sharpie's fibers. It contains more calcium and it appears darker on H&E sections and more dense in the radiographs. That is why this bone is also seen as a white line, which is called as laminar dura. The alveolar bone proper has another term, that is cribriform plate, because it contains numerous perforations for interalveolar and intraalveolar nerves and vessels. It also contains the canals of Zuckerkandl and Hirschfeld, which are interdental and interradicular in the interdental and interradicular septa. This is the interdental and the interradicular septa. The interdental and the interradicular septa, they also contain the canals or perforations which are called as Zucker-Candle, and Hirschfeld. The lamina dura is the term used for radiographic appearance of alveolar bone proper, and on the radiograph, as we can see here, it is seen as a white distinct line which shows the integrity of the alveolar bone surrounding the tooth. So increased radiopacity of the lamina dura is due to the presence of thick bone without trabeculations. The structure of the alveolar bone comprises of cortical plates and spongy bone. Or the supporting alveolar bone comprises of cortical plates and spongy bone. Now, the cortical plates are the outer and the inner plates of the alveolar process. In the maxilla, they are thinner, and in the mandible, they are thicker. And on average, they are thicker in the premolar and the molar area. So, any defect or lack of continuity of the cortical plates of the supporting alveolar bone will be termed as a fenestration or a dehiscence. A fenestration is what is marked as F. This is seen as a window defect, while a dehiscence is a continuous defect which also involves the marginal bone. The histology of the cortical plates consists of lamellar bone and Haversian systems. Spongy bone is seen between the cortical plates and the alveolar bone proper, and it contains trabeculae of lamellar bone. In the anterior region of the jaws, the supporting bone is very thin and the spongy bone is absent. Coming to the histology of spongy bone, it contains trabeculae of lamellar bone with marrow spaces in between, and radiographically, there are two types of trabecular pattern that can be seen. In type 1, in the mandible, it has a regular pattern which is called as a step ladder arrangement or a ladder-like arrangement, while type 2 arrangement is seen in the maxilla. This is irregular arrangement containing numerous delicate interdental and interradicular trabeculae of bone. The cortical plates and the cribriform plate meet at the alveolar crest. This would be the alveolar crest between the two teeth. There is a crest of bone which is called the alveolar crest. This is usually about 1.5 to 2 millimeters below the cemento-enamel junction. The shape of the alveolar crest depends on the position and the CEJ of the adjacent teeth. So if the teeth are tilted, there will be a change in the morphology of the alveolar crest. And if they are malaligned or not fully erupted, positioned, there will be corresponding changes in the alveolar crest position also. With that, we come to the end of the histology of alveolar bone. Thank you.